Good evening. This is a presentation on cybernetics in therapy. My name is Philip. I'm from the University of Johannesburg. A little bit about me. I've been working for the South African Police Services Trauma Unit. I've been doing therapy for some few years. We're dealing mainly with crime, dealing with domestic violence, abuse. I have a Western background, and I'm running the ecosystemic psychology organization in South Africa. The premise of my presentation is that psychological problems arise in a relational context. The problem that I've noticed is that in mainstream universities, it's very difficult to find cybernetic approaches in psychology. And that doesn't make sense to me because cybernetics, patterns, relationships, so there should be an obvious fit with cybernetics and therapy. And the role of cybernetics in psychotherapy is invaluable. Some practitioners have heard of cybernetics, but most have not. So the status quo, Western thought adheres to linear causality. Problems have causes. The person with the problem is the patient. The problem lies in the person presenting it, the client. The client presents a problem. Diagnosis, diagnosis, and more diagnosis. Let's go label shopping. The therapist is separate and external to the client, and the therapist takes the stance of the expert. People are information processing beings. A little bit about me. This is a personal note. When I was introduced to cybernetics in psychology, my world was turned upside down. I took the infamous red pill, if you've watched The Matrix, which I'm sure you have. I was depressed for about 2 weeks. And this is a process I've seen in my students and people who come to the organization. Also, I'm a classical engineering student, so cause and explanation of causes is central to how I see the world. I agree with cybernetic thinking, and I had a challenge of marrying this type of thinking into my linear world. And there's a paradox with cybernetics. For example, this desk here is hard, but from another viewpoint, maybe an atomic viewpoint, it's mostly open space. So we deal with this paradox. And I run a difficult explanation, a difficult line in I don't want to negate cybernetics by the very explanation of this. So justifying cybernetics used in therapy. How did I do this? I revert to physics and biology in an attempt to calm the engineer inside of me. Psychology is often termed a soft science. So let's use hard science to silence the critics and bring cybernetics back into the mainstream psychology arena. After each principle that I present, I will give a real-life case scenario from my therapy experience. The free fall. Opening up to a stranger is daunting. So deconstructing the therapeutic encounter. I welcome cybernetics. It is difficult and probably incorrect to prescribe cybernetics into therapy as some sort of model. Cybernetics cannot be a model. A model is something that we can put on a pedestal and view it as though it contains something repeatable for every observer. Rather, spontaneous relative meaning. Did I say relative? Yes, I did. So let's call Einstein. Western thought holds science as the highest point of reason and prizes objectivity. But using Einstein's example, he departed from the norm. He looked at the experiments and assumed the findings were true, even though they were unpredictable. This was the exact opposite of what most other physicists were doing. Instead of assuming the theory was correct, and that the experiments failed, he assumed that the experiments were correct and the theory had failed. So his experiential knowledge was more valuable than his conceptual theories or beliefs. An example in therapy. I have studied psychology and psychopathology, but the problem is that will get in the way. I need to follow Einstein and allow the tangle between myself and the client as I experience this unpredictable encounter, the client and myself. Walking into a session, I cannot drop my beliefs and values, or as many teachers say, leave your preconceptions at the door. That's not possible. What I can do is take a stance of not knowing. Curiosity manifests itself in an environment of seeking and understanding. I need to take a stance of realizing that I do not have exact answers as to how the behaviors of family members need to be. An awareness of my own ego and arrogance in that I cannot know for sure how to solve the problem. Curiosity is lost by a therapist who is a know-it-all. And I think that's also key in what we've been doing the last few days, is if I already know, then I cannot learn. So Einstein said, if you move fast enough through space, the observations that you make about space and time differ somewhat from the observations of other people who are moving at different speeds. What does this mean? It means that if I've got a clock on the wall here, and you as a group are sitting here, the time that you see will be different to the time that I see if I am in motion. So we all have different epistemologies as products of our unique lived experience. Thus we in turn experience the world as unique observers. I realize that my knowledge is relative. I engage the client in a conversational dance. I now believe that the client's knowledge is equally valid as mine, it's just relative. Relative to the context of my lived experience, my position in the room is connected to the client's position as we both move through the therapeutic encounter and share this space and time. I call it relative subjection. So deconstructing the word the therapist, and I've written it like that for a reason. What is a therapist? A person trained in methods of treatment and rehabilitation other than the use of drugs or surgery. So we would say they're a specialist. But if we share this space and our knowledge is relative, who is the expert? The client is the expert in their own life. Heck, they lived it, not me. I call into question the expert status of the professional. I rather use Watzlawick's term of a change agent, not a therapist. Questions or comments that begin with phrases like, could it be that, or what if, immolate or reduce the professional persona and enhance participation. Taking notes is often important in the session, and I've been doing that for years. The problem is it's an unintentional separation, and as much as I say to my client, I've got this notebook here and it's just so that I can remember at a later stage what we discussed, and you're welcome to see the notes, there are your notes. Every time I write things down, a boundary condition takes place. That person cannot see what I'm writing.
Do they ever write things down?
People don't normally come into therapy with a pen and paper, and they should. And that's coming to the next point. Let's co-create the notes, and you, the client, are part of this. So help me in choosing the best words that suit you. Now that looks like a much more relaxing scenario. Let's share our invisible thoughts. Let's look at the patterns together. If we deconstruct the posture too, what is emotional posture? Where are you at in the session? An awareness of the influence of bodily states. Bodily states that show care, trust, sharing, and active listening promote reflection as a process of meaning reconstruction. An awareness of facial expressions, posture, breathing, tone of voice, eye contact, and direction of gaze help to improve one's understanding of what is manifesting in therapy. We are aware of incongruent bodily states. Is there congruency between the verbal and analog information? Just looking at the figures on the top left there, that figure is saying so many different things with just his posture, not to mention the other people on the screen. I wonder what reality I am participating in creating. Am I responding to what the client has just said or to what the comment meant to me? I introduce biological filtering. Our senses are unique in their sensitivity to external stimulus. Are colorblind people allowed to get a driver's license? My 15-year-old son would ask. How will the red light be differentiated from the green? Well, if I know the green is always placed on the bottom of the traffic light, then that's enough information to construct meaning. The eye has a visual field. The visual field contains a blind spot. As there's a lack of light detecting photoreceptor cells on the optic disc of the retina. The reason for this is that the optic nerve passes through at this point, and thus the visual field is blank at this location. So we are actually filling in the missing information, creating the complete picture. Further, about 20% of neural stimulus that is interpreted by the brain as visual information has originated from structures other than the optic nerve. Originated from structures that the optic nerve travels through, the thalamus and the nearby hypothalamus, of which we still do not know the exact function of what the thalamus is. Maybe to do with homeostasis. If I walk into a room and I'm cold, brought to my awareness is there's a jersey on the table. If I wasn't cold, I may not have noticed that. Secondly, if we look at psychoacoustics, for some time it was thought that sound is mainly associated with the ear, and that sound can be explained in terms of physics, while the process of hearing can be narrowed down to mechanics. One fascinating research challenged the idea of there being a fixed upper frequency limit of 20 kilohertz to human hearing. Tsutomu and colleagues set up a listening experiment where they played back a recording that had active frequencies up to 60 kilohertz. They set up a speaker system and included an independently excited tweeter that was to excite frequencies above 20 kilohertz, 26 kilohertz. The tweeter was switchable on and off. Included in this experiment, they also had an EEG connected to the respondents. The finding was that the subjective evaluation of music played was altered by whether the high frequency tweeter was turned on or off, and they also observed changes to the EEG, even though we know we cannot mechanically hear above 20 kilohertz. And most of us in this room are probably at about 17 kilohertz, and those with the gray hair may be at 15 kilohertz. So my case example is as follows. I can no longer rely on my senses for the truth. I hear you with my ears? No, I receive sound energy, not meaning. I see you with my eyes? No, I receive light energy, not meaning. There's my blind spot in the mirror. Here are the Dadson curves. Look at the frequency response of the human ear. My confidence and arrogance have no justification and no purpose. We deconstruct labels and diagnosis. People look for labels when they are confused, and thus it is very easy to fall into the trap of labeling behavior. The Milan group, Luigi Bascolo said, once labeling has been accepted by the family, then all behaviors are related to that labeling. You are cooperative, you are good, you are bad. It is like being cast in a role in a play and never being able to get out of it. If you say, I get along with my son, we have fun together, that is relational. But if you say, my daughter is intelligent, you use words to kill the relationship. To unstick that kind of system, you must bring in a process that helps people get away from labels. Not only negative ones, but positive ones too. Diagnosis only exists in the eye of the observer. Diagnosis attributes causality and hence blame, which acts to reinforce the problem they are meant to explain. The problem is only valid if the client, him or herself, sees it as such. Thus, there's an emphasis on the way the client defines it. How the client communicates about his or her problem is more important than the problem itself. A reinterpretation of Nietzsche's master-slave morality could see the diagnosed as the slave cooperating with the handing down of mental diagnosis. A context is created that frames behavior as abnormal, requiring treatment. Now more than ever, many children are ADHD. Some children learn with movement, but sitting in a class for 7 hours a day is normal. Needing to move freely is now abnormal. If you do not fit with this model, you have a problem. And my 15-year-old son, who has this condition of ADHD and needs to move while he learns, and his teacher says to me in parents' evening, "Your son is getting up 5 times during maths." I say to her, "Yes, and what's the problem?" "He's sharpening his pencil 5 times. I'm like, again, what is the problem? Is he doing bad in your class? No, actually he's getting above average, close to distinction. So, right, so what is the problem? Is he disturbing other students? No. I said, again, what is the problem? I do not want to cooperate with that. But who is the observing system? What is the problem? About 15 years ago, avocados were rated as a do not eat food for people with high cholesterol. Now, they're in the top 3 foods of you must eat. What's going to happen in 10 years' time with all the medication that people are taking? A case example, what I do with diagnosis. Yes, I understand medical aids need an ICD-10 code for claiming of medical aid. I let the client see the DSM manual, and together we can discuss the idea of labeling. In some cases, the client can choose their own label. As easy as the client can say, "I have clinical depression," is as easy as they can say, "I do not have clinical depression anymore." There was a case of a person diagnosed with disorganized schizophrenia, with delusions. The client kept saying, "I'm not crazy." After 2 weeks in care and medicated with some neuroleptics that you cannot reverse some of the side effects, lip smacking and so on, the condition settled down, but that reoccurred after a while. It was only after a third party outside the hospital had said, "This person is suffering from an abdominal obstruction." Once their bowel was cleared, sanity prevailed. Can we trust the client? I am connected to what I see. Neutrinos are electrically neutral, virtually massless elementary particles that can pass through miles of lead unhindered. Some are passing through your body as you read this. People have magnetic fields surrounding them. Is it possible that we are connected to each other on an unconscious level? So, to sum up, Western thought adheres to linear causality. We construct our world, including any cause-effect relationships. We own these causes as they are personal. Problems have causes. The person with the problem is the patient. The problem lies in the person presenting it. Rather, the observing person who sees the problem is also part of this problem. The problem also exists in the neurology of the new observer. Diagnosis, diagnosis, and more diagnosis. You need medicine and therapy, and you need to pay for it. Diagnosis is based on an agreed upon social standard. Western thought would say the therapist is separate and external to the client. I would say the two are co-creators of the therapeutic environment. The therapist is the expert. No, the client is the expert in their own life. People are information processing beings. No, we are meaning generating beings. And there's just a statement from a citation from Anderson and Gulish, and she says, "You, the professional, are always checking me out to see if I knew what you knew rather than to find a way to talk with me. You would ask, is this an ashtray? To see if I knew or not. It was as if you knew and wanted to see if I could. That only made me more frightened, more panicked. If you could have talked with the me that knew how frightened I was, if you had been able to understand how crazy I had to be so that I could be strong enough to deal with this life-threatening fear, we could have handled the crazy together," stated by someone previously diagnosed as a paranoid schizophrenic. That is it. Thank you.
Thank you. Okay. I think we can have one question. No question. Silence.
Let's enjoy it.
Sorry?
Silence. We should enjoy it. Thank you, Philip.
Thank you. Pleasure.
There was one question.
I was just going to ask if you think you made any paradoxes.
If I?
Just go back to your first comment and whether you think you created any paradoxes.
Yes, because I don't want to stand here as someone advocating a method. So I tried to show process and metaphoric language, if you will. I tried not to say do this or do that, don't do this, and I hope that came across.
How's it working for you?
Yeah, it's challenging because it puts me always on the spot. Problem with therapy is you walk in and then what am I going to do? What am I going to say? And I tried to just be more relaxed and let it be spontaneous. And to allow a conversation to be spontaneous for me is much more effective than to try and construct. I believe you cannot engineer relationships. They're spontaneous.
It's interesting because I've heard therapists tell patients that the problem lays on other people outside. So it's not the patient's fault, it's the patient's family's fault, for example.
Yes. And the word patient already gives the idea that this person needs treatment. Just the language is a problem.